Good day, Mr. Israel. Could you please do a focused cardiovascular exam on this patient? Good day, sir. How are you?
Good day, doctor.
Good. My name is Israel Shingenge. I'm a fourth-year medical student. I've been asked by a doctor to do a cardiovascular exam on you. It will involve me touching you, looking at you, and telling you to do comments. Is it okay with you?
It's okay.
All right. Could I ask you please to remove your shirt?
Yes.
Okay. So, the examination starts from the inside of the bed, okay? You want to see, okay? I'm examining a young adult, okay? Who's of average build, so you want to know the weight, okay? Remember, if someone is obese, that's a cardiovascular risk factor. If someone is cachexic, you're thinking he has been having long-standing cardiac problem, what you call cardiac cachexia. So it's a giveaway, okay? You want to see, is he appearing to be in any respiratory distress, okay? Or is he fine, okay? A giveaway always for respiratory distress on cardiovascular exam is a patient who has multiple pillows behind, okay, which shows that he's orthopnic. That's why he has to be propped up, all right? So all those are giveaways that you can see from afar. Another thing you want to pick up is to make sure that there are no obvious adjuncts, okay, IV lines. Is the patient having oxygen? Any adjuncts that you can see, that you can pick up at the bedside, I cannot appreciate. Another thing that you can actually add is the patient appearing just from afar syndromic, okay? You have certain syndromic features such as for Marfan or for Turner syndrome that have cardiovascular manifestation, which we are not. And finally, remember, this is the only time you see the chest symmetrically because we are at the inside of the bed. From the side, you are biased, okay? So you want to know, is there any obvious precordial deformity that you can see from afar? Otherwise, we move on, okay? Could you please give me your hands? So you take both hands. So on the dorsum aspect of the hand, you look for typically three things, okay? You want to see, is there any obvious clubbing, okay? And we cannot see any softening of the nail bed. We can see a drumstick appearance. We can see the loss of the angle, although ideally you would do it to look for the Schemreth angle, okay? Otherwise, we can't see any obvious clubbing. And remember, you need to know the cardiovascular causes of clubbing, infective endocarditis, congenital cyanotic heart lesions, and of course the rare one, atrial myxomas, okay? Again, you look, is there any obvious splinter hemorrhages? We cannot appreciate any splinter hemorrhages. And finally, you want to press the nail bed to see for the capillary refill, and that is less than 2 seconds. Then you flip on to the palmar side, okay? Again, feel, how's the temperature? This feels very actually cool, okay? Because if something was very cold, you think, oh, is a poor perfusion to the periphery, is the patient in shock, is a decreased cardiac output. That's how you think. Another thing you can check for is to palpate, especially the 4 parts of the fingers. You will be able to pick up nodules, okay, osseous nodes, and they are typically very tender, okay, which we cannot see here. And also on the palmar aspect of the hand, these typically where you see Janeway lesions. They are macules, typically non-tender, which we cannot see here. Okay, and finally, you want to see is there any obvious peripheral cyanosis. Then we move on to the pulse. Okay, so the pulse, the peripheral pulse like this, the radial, you want to assess for 4 main things. Okay, you want to assess the rate. Okay, because we don't have a watch officially, you say, oh, it appears normal. So the rate. Then you want to know the rhythm. Is it regular? Is it irregular? Is it irregularly irregular or irregularly regular? Okay, then I can appreciate that the pulse is regular here. Then the next thing of the 4 things that you want to know on the peripheral pulses is there any obvious radial delay? There is no radial delay, and you can check for radiofemoral delay, and there is no radiofemoral delay. And finally, say, do you have any pain in your arm? Okay, so just relax it. We are trying to test for the character, and typically this way you can pick up an obvious. So you raise it quickly. I cannot appreciate any collapsing pulse. Remember, there are other pulse types of characters of pulse, such as pulsus alterans, that you can pick up, okay, which I cannot appreciate here. And as you move up the limbs, you want to say, ideally, we'll do a 4-limb blood pressure. All right. Then we move on to the face, okay? Okay, could you please look up? Okay. there is no pallor. Okay, remember, anemia is a precipitant of heart failure, so it's useful to pick it up. Okay, would you please look down? There is no jaundice. Jaundice can occur in cardiac problem if you have long-standing right-sided heart failure. It strains the liver and it starts failing. So a long-standing heart failure, especially the right-sided one, it will cause jaundice eventually, okay, which we do not see here. Okay, could you please open your mouth? Okay, again, you want to look at the palate. Is it high arched to suggest conditions such as Marfan syndrome? Look at the buccal mucosa. Can you please stick out your tongue? Lift it up. Look at the ends under the tongue. There is no obvious cyanosis, which will be in keeping with central cyanosis. Okay, you can close it. And finally, just open it. You want to see how is the oral hygiene. Okay, we know that if the oral hygiene is poor, you're thinking it's a risk factor for developing infective endocarditis, and that should suffice for the face. Okay, remember the neck. So say I will ask you to look here. The neck, this is where you typically assess for two things, the carotid and to assess for the JVP. Okay, it's always useful to enter an OSCE, not going there thinking that it's a JVP or it's a carotid, rather to look and to first give the characteristic, then you say it's a JVP. Okay, so look. Okay? So let's say, for instance, we're seeing a pulsation. You say, oh no, doctor, I see an obvious pulsation. Okay, it seems to be between the two heads of the sternocleidomastoid. That's 2. It has a biphasic waveform, so it's twitching twice like that. That's 3. And doctor, as I palpate the radial pulse, it's asynchronous with the pulse, okay? Because this pulse is it's arterial, and this is venous, which is the JVP. If they are beating together, then you're thinking it's a carotid pulsation, but that they're asynchronous with the pulse, okay? And other maneuvers you can also do, you can tell the patient to stand up erect. It typically drops, or in inspiration you notice it drops. Okay, again, those are characteristic to qualify. And finally, you palpate. We have inspected for 4 main things. I'm seeing a pulsation. It's biphasic waveform. I'm seeing that it's between the two heads of the sternocleidomastoid. Okay, and it's asynchronous with the pulse. Now you want to palpate. So let's say you are seeing a pulsation there, which I am. So you want to lightly just occlude it. Remember, don't press too hard, otherwise you feel the carotid, which is just next to it. Okay, so you do that, and then you see it disappears, which means you have occluded it, and it's a vein that you can occlude. Very rarely can you occlude an artery unless it's small. Okay, so you see it's occludable, but I can't palpate it under, so it's non-palpable. I think this is most likely a JVP. And remember, you have to formally, to say it's raised, you have to formally actually measure it. We don't routinely always do it in an OSCE, but it is useful to know that anything greater than 8 centimeter, you are thinking that is this, you know that the JVP is raised. Then the other thing you can palpate for, you can come back, sir. Okay, remember the carotid is much more medial as opposed to the internal jugular, which you assess for JVP. So what you do, the technique is you can palpate the trachea like this and just slide just next to it. I'm already feeling the carotid. And this is the time you talk about volume. You notice I did not talk about any volume on the peripheral pulses. Okay, then you say no, the volume appears to be adequate or full. Remember, for edema, it initially collects just around the medial malleolus here. So that's typically where you want to press for a while and check. Okay, so moving on to the closer inspection of the chest. Okay, you have to check, is there any obvious scars? Okay, scars are very, very important in any exam. Okay, because you want to anticipate the pathology. If you're having a scar just infraclavicularly on the left, you're thinking it's a pacemaker scar. If you are having a scar going through the sternum, what you call a midline sternotomy, you're thinking that the patient had what we call a cabbage, okay, as opposed to someone having either a anterolateral or mid axillary or posterolateral thoracotomy, which will involve other things that could have operated. So it gives away what a possible operation was done for this patient. Okay. Another thing that you have to inspect for is there any obvious precordial deformities, pectus carinatum, pectus excavatum. You see that in conditions like Marfan syndrome. Okay, so it's very useful. Chronic asthma again causes precordial deformities. COPD, if you are thinking maybe it's causing pulmonale, again you see that barrel chest, or you see again precordial deformities. Okay, and finally you want to know, is the precordium active, is the precordium quiet, or it's completely hyperdynamic, hyperactive precordium. So it's very useful to know that. Okay, now moving on to palpation. Okay, palpation, you only palpate for three things: the apex bit, which is very important to know that it's the most inferior, most lateral. So it's the most inferior, most lateral, not the most point of maximal impulse. Okay, so what you want to do, because of that in mind, you want to start as lateral as possible. Okay, you want to start locating, then you find that it's there. Okay, then you take your other hand, you sweep the sternum. Okay, and typically you feel a ridge here. This is the sternal notch, the sternal angle, the angle of Loewe between your manubrium and your sternum. Okay, that sternal angle, once you slide just, because it connects the second intercostal, so if you slide just below is your second intercostal space. Okay, then you go from there, that's your third, then you go from there, that's your fourth, then you go, that's the fifth. Okay, so you think, no, the apex bit is mid clavicular, and it's in the fifth intercostal space. That means it's not displaced. Okay, it's useful to add more characteristic to an apex bit, especially if it's pathologic. You want to know first, is it palpable or non-palpable? You must know the causes of a non-palpable apex bit. Number two, you want to know, if it's palpable, where is it displaced to, so the location. Okay, so number three, you want to add, what's the character of the apex bit. Okay, you want to know, is it pressure loaded, is it volume loaded? These are mainly very important, but you can also describe an apex bit. Is it dyskinetic? Okay, is it a tapping? Okay, you want to add more characteristics. So for example, if it's pressure loaded, it's typically very localized to one area, very forceful, very sustained, but not displaced, as opposed to an apex bit that is volume loaded. Okay, so you are thinking about your things like severe aortic regurgitation, severe mitral regurgitation. Okay, those gives you typically your displaced apex bit. So the volume loaded would typically be very diffuse, not sustained but displaced. Okay, as opposed to other types of apex bit characters such as dyskinetic, where it's typically very uncoordinated and occupying a larger area. Okay, it can be double impulse, where you are feeling two marked areas with systole. Okay, and finally it can be tapping. Okay, seen in mitral stenosis, when you can palpate the first heart sound. Okay, so you need to add more character to your apex bit. Okay, moving on. Okay, you want to feel for your thrill. Okay, thrill, remember, it's a palpable murmur. Okay, you use this aspect of your hand, okay, at all the valve regions. So you feel for the mitral region, the tricuspid region, the pulmonic region, and your aortic region. I cannot appreciate any heaves. And finally, you want to know your precordial lift, okay, what we call a heave. Okay, so there are two areas you can assess for it: the left parasternal heave, which will signify most likely a right ventricular hypertrophy. So what you use is this part of your hand. Okay, so you want to put it on the chest like this, and then in kids, it's typically, it can be very obvious, but in adults, it's not always obvious. So you may want to look, okay, and you will see an obvious lift that you are picking up there. And another area you can look for is at the apical heave. Okay, here you pick up typically your left ventricular hypertrophy if they say apical heave. So you put it there. Again, I normally just look like that, just to make sure there is no lifting. Another alternative you can do, you can just take a pen and put it there, and you can typically see it being lifted. Again, that's an alternative that you can do. Okay, so before we move on to the auscultation part of the examination, always just to add on the apex beat, always know the differentials for a displaced apex beat. I'll list some of the cardiovascular ones. However, apex beat can be displaced for other reasons. Okay, but the main cardiovascular causes of displaced apex beat, you have to think about dilated cardiomyopathy. You have to think about severe aortic regurgitation and severe mitral regurgitation. Typically, those gives you a displaced apex beat. Okay, so for auscultation, always remember your stethoscope has two sides. This is a standard stethoscope. So you have your diaphragm, which is your larger aspect. Typically, this picks up best, especially your systolic murmurs and your S4. Okay, your systolic murmur and your S4 are picked up very well on this side. Okay, and your bell, which is your smaller side, typically picks up well those low pitch sounds, the diastolic murmurs, and an S3. Okay, you typically hear them much better. Okay, so the rule of thumb is that you can start from the aortic region moving in a Z line. You can start from the apex. Okay, standard books typically start from the apex or that, but it shouldn't really matter. Hope is that if you are hearing, say, on the mitral region, a systolic murmur, it's very pointless for you to turn the knob in that valve area to check for the bell, because the systolic murmur will be so loud already that you will not be able to hear a diastolic on top of that. Okay, otherwise we start. So I'm just going to listen to your chest. Okay, so remember, while you are putting it on the chest, you feel for the pulse. Okay, so you'll be able to time it. Now, we can add some information on auscultation. Okay, so what you need to know is that when you hear, say, a murmur, say anywhere, number one, you have to characterize the murmur. Okay, what are you hearing? Firstly, where is it, the site? Okay, where is the location that you're hearing it? Are you hearing it on the mitral region, the pulmonary region, the aortic region, or the pulmonic region? That is useful. Okay, you have to add, because the problem with murmurs is that if it's in one valve area, it's very likely that you hear it in the other valve areas, okay, because it radiates to the other valve areas. Okay, so you want to locate where it's loudest. That's probably where the pathology is. So where is the site where it's loudest? Number two, you want to know, as you are listening, is it a systolic? So the timing we're talking about, is it systolic or is it a diastolic murmur? Again, that helps you differentiate your differential of what you're dealing with. Number three, you want to know if it's, for example, systolic. You can further describe it. Is it hollow systolic throughout systolic, or is it mid systolic, or is it late systolic? Okay, and then your diastolic, again, they can be early diastolic or late diastolic. Okay, again, other characteristic you can add is that you want to know, now that you have a murmur, say, on the apical region, you want to know what's the grade. Remember, we use the Levin's grading system from 1 to 6. Most of us, as we are junior, you probably start hearing the murmur from around 3 if there's no thrill, and 4 if there's an associated thrill. Okay, most. Okay, 1 and 2 are typically consultant level. We use very sophisticated stethoscope to pick up those subtle sounds. Okay, so most your winning zone will probably be around 3 if there's no thrill, or above that if there is a thrill. Okay, so that's useful to know. Another thing you can add on the murmur, you can add, if you know the cardiac cycle and how it works, you can add the shape. Okay, if it's crescendo, decrescendo, it's just decrescendo, a shape is also useful to add. And finally, once you hear a murmur, you can add what we call dynamic maneuvers. Okay, dynamic maneuvers are useful, but before I talk about dynamic maneuvers, always know that murmurs can radiate, especially the systolic ones. We know a systolic murmur on the apical region, typically from mitral regurgitation, typically radiates to the axilla. And so once you hear that, you want to hear in the axilla to see it radiating. It's the same with the aortic stenosis, that in the aortic region that you typically hear, typically what we call an ejection systolic murmur, mid to late systolic murmur, that typically radiates to your carotid, your neck. Okay, so that's useful to know. However, there is one diastolic murmur that typically radiates, and that's your aortic regurgitation. You'll be hearing it in the aortic region, the diastolic murmur, but you go on the third intercostal space on the left, you go at what we call Erb's point. That's where it typically radiates, and you can do what we call dynamic maneuvers. Okay, now if it was a diastolic murmur are harder to listen, and typically we want to accentuate them to make them worse, although you can also do it for your systolic murmurs. Okay, so what you want to do is, say you are hearing a murmur on the mitral region. Okay, so what you want to do is to say, could you please lean, you slide to your left. Okay, again, you're trying to listen, is it getting louder? Because now you're trying to get the heart closer to the chest, which will typically accentuate your murmur. Okay, the same is true, especially if you are dealing with, for example, a aortic regurgitation. You would want, after you have come from here and picked up that there's a diastolic murmur, you come at Erb's point. You can calculate that's a second, that's a third, and tell the patient, could you please sit and lean forward. If you are even you even want to characterize it more, okay, you can sit, you can add the respiration. You tell the patient, remember, all right-sided murmurs, they get louder on inspiration. All left-sided murmurs, they get louder on expiration. So we know that the aortic valve is on the left. Okay, so you tell, say, would you please breathe out and hold and lean forward. And again, you will hear the murmur much more pronounced. So because you are actually bringing it out, and it becomes much louder to hear. Okay, those are just some of the dynamic maneuvers that you can do. There are many more. You can do Valsalva maneuver, tell them to blow without letting any air out. Again, it worsens certain pathologies. You can tell them out of context now to do squatting, but those are things that are not routinely done in an OSCE. However, you must be aware of them. Okay, and finally, after you have characterized your murmur and everything, that's where you pick up your differential. That marks the end of the cardiovascular exam. Now, to end off a cardiovascular exam, always remember that it is useful to listen to the lung basis, especially if the patient is sitting. It's very useful when he's sitting, because you can pick up by basal crackles, which will suggest pulmonary edema. So you are thinking, is this patient having a left-sided heart failure? Okay, and again, it is useful to palpate the abdomen to pick up any hepatomegaly. Okay, if you're having right-sided heart failure, tricuspid regurgitation, you can have a liver that is enlarged. Okay, and it's typically very pulsatile if you're dealing with things like pulmonary hypertension or tricuspid regurgitation. It becomes very pulsatile. Okay, and another thing that you can say how you would want to end off your general exam, your cardiovascular exam, is to do all pulses. Okay, we don't routinely always do it, but always remember, the moment you pick up a significant pathology on one of the pulses, it is useful to palpate all the peripheral pulses that you can palpate. Okay, and finally, although this is facing out, this is the last thing you do on a cardiovascular extended exam, and that is the abdominal jugular reflux. Okay, so what you do is, could you please look there? So you want to apply firm pressure just on the epigastric region, and you look for a rise of the JVP. The JVP is normally supposed to rise. Okay, so you give it there for a few seconds, and we can see a transient rise, but as I leave, then it disappears, and that is a normal finding in a patient who has especially right-sided heart failure. They will be sustained increased JVP, and that will suggest that there is a pathology there. All right, but this is typically very painful, and so we do it last, and that marks the end of the cardiovascular examination.